evening, everybody. It's a full house tonight. Welcome to the living room. I see some new faces. Thank you all for coming. And hello to everybody who signed in online. I hope after last living room, some of you online maybe who didn't want to tell us who you were, at least where you were from, will reconsider that tonight. And I think most of you will notice that Bonnie's not here tonight, or Mom, as I call her. She's in New York doing filming, actually, for HBO. So keep your fingers crossed that all the filming goes well tomorrow and that we get some good footage out of it. And I'll let you guys know more about it once she comes back and we know when it's going to air. She was going to try to sign in tonight, so hopefully Tony's there helping her, and she'll be able to get online. So tonight, as you guys know from the plethora of emails and now MailChimp's, not formerly vertical responses that you've gotten from us, tonight we're talking about the community hospital and lung cancer and the importance of cooperative multidisciplinary care in the community setting, which, as you all know, because we've talked about ad nauseum, is where roughly 80 to 85% of the patients are seen. So it's really important that we take academic sort of practices and really identify the community centers who are seeing the patient populations, identify those groups that are doing top-notch work in lung. And these two gentlemen to my right are in from Tennessee. I've known Dr. O. So I'm gonna hold on for a second. I am insanely embarrassed by the fact that I still cannot pronounce his last name. And just when I think I have it, I'll say it again, and he's like, yeah, no. So Dr. O, you're gonna pronounce it?
OSAROGIAGBON.
Yeah. Did you hear that?
It keeps going.
Yeah, say it 5 times really fast. It's not going to happen. And Dr. Robbins.
His own children cannot say
right?
his name.
See,
I am not joking. They cannot say his name. And it's their name.
And when we were out in Memphis at Baptist, and I had all these other docs who were like, oh, DL, it's not that hard, just blah, blah, blah. And I'm like, no. So anyway, we very fondly refer to him as Dr. O and Dr. Robbins. Dr. O is a medical oncologist, and Dr. Robbins is a thoracic surgeon. We're gonna, you guys have all of the, for those of you who didn't read your emails, there's a little bio on both of them here. Please read. So with that, I'm gonna do around the rooms. Again, it is a full house, so please, let's not do like total treatment history, just who you are, when and what you were diagnosed with, and then we'll move on. We'll have time for sort of more treatment detailed questions and conversations once we get to the Q&A part of the program. So, Elizabeth, do you want to start?
Sure, why not? Hello, gentlemen. Welcome. My name's Elizabeth Lacasia. I was diagnosed with bronchioalveolar carcinoma, adenocarcinoma, in 2006. I've had 2 surgeries, a lobectomy and a wedge resection, have been on several different types of chemotherapies. Just one thing I wanted to say was that, just to give an example of how much things have changed in the time since I was diagnosed, when I first had molecular and genetic testing done, they were only testing for 7 different mutations at that time. That was through Response Genetics. About 8 months ago, I had another follow-up test done by Foundation Medicine, who is now doing a panel of almost 500, I believe, different types of mutations. The first time I was tested, they said that I was wild type. This time, we found out that I was ROS1, have the ROS1 mutation, and quite strongly so, 73% positive. So I'm now on Xalkori because I progressed, and I just got my scan, and I was told that I am NED, no evidence of disease, once again. That's my story. I'm sticking to it.
Thanks, Liz.
Hi, my name's Mary Basso, and I was diagnosed with stage 4 lung cancer, non-small cell, in October of 2010. And I had chemotherapy the first year. The second year I had radiation, and then no treatment for 10 months, and then I went on Tarceva. And was on Tarceva for over 2 years, and now I'm on afatinib, which is a kind of a targeted for my EGFR gene mutation. And I've had CyberKnife, which I'm very grateful to the people that designed that. And it's good to be here.
Thanks, Mary. You guys should have a mic on your table. Sally.
Good evening. My name is excuse me. Good evening. My name is John. I was diagnosed December of 2014, stage 3B non-small cell. I currently just finished my second round of chemo and radiation and waiting for a PET scan to be done.
Hi, my name is Neil. It's N-E-I-L. I wanted to change it to N-E-D, especially after hearing Elizabeth, but I'm not quite there yet. I am going to Boston tomorrow and going to be at Foundation Medicine on Thursday, where they can do whatever they want with me, but I'm going there to learn some things from them. So I was diagnosed about 4 years ago. I go to treatment at Stanford. I feel I'm very fortunate that I live in the right zip code, so that in this area here, we do have tremendous resources. And I know that you...
Bueller.
I always like to take things apart as a kid. Still with me, but I'm going back for my 50th high school reunion, which is unbelievable. That 50 years could have passed so fast. But being out here in this area, we have a lot of great, places to go for clinical trials, especially for treatment. And I do speak to a lot of groups about clinical trials and how important they are. And I know the work that you gentlemen do in your area there makes it much better for everybody who lives nearby. But there are so many other places in this country that you do have to travel tremendous distances. You may be of lesser means, so you can't get those type of treatments. But what you're able to provide and what the foundation is able to set up in the centers of excellence that they've been working on throughout the United States will bring a little more parity to the types of treatments. Because whatever I get, whatever drugs I've been able to get, should be available to everybody in the United States. But it's not that way. But I know that we're getting a little bit closer to it, and it's because of the work that you're doing in an area that may not be, or some of the areas are not as good as far as what zip code they're in, but you do provide those resources to them. So thank you very much.
Thanks, Neil.
Hi, I'm Sally, and I entered the International Early Lung Cancer Detection study that they were doing because I was at high risk for 2 reasons. I had smoked for 30 years, and I had family members on both sides of my family that had lung cancer. And after the 5th year, one of my nodules grew. I had a lot of little nodules. And I was very fortunate because it was found early. I had surgery, my lower right lobe was removed, and I have been NED for 6 years now. And can I just put the luncheon thing in here now, Danielle?
Sure.
Okay. Tina and I are organizing a luncheon on Monday, May 18th at Madeira in the Rosewood Sand Hill restaurant in Menlo Park. It's a no-host luncheon, and we'd like to offer an open invitation to anybody that's going to be in the area or any of our group here or people watching us on TV. Just let us know. We need to have it numbers by about May 8th. So
Sally, if you just send me sort of the time and date. I know it was brief, and then Michelle or I can send it out to the group.
Terrific. Okay. That would be wonderful. Sure. Thank you.
My name is...
Oh.
There we go. Yeah, it's all Neil's fault. I was diagnosed 4.5 years ago, and I tested positive for EGFR at that time, and so I did do radiation and chemotherapy, and was NED after that, and then I've been on Tarceva for nearly 3 years, I think, and all's well in ED. So that's, want to stay with that story.
I'm Rick, excuse me, and I'm Tina's husband, and I've been through this journey with her, and she has done one hell of a job. And I'd like to, again, thank this foundation for all their support.
Thanks, Rick.
My name is Athena, and I have stage 4 lung cancer. I've had it for 2.5 years, and my only treatment has been Tarceva, and I'm still doing good on that. And I also have stage 1 breast cancer.
Okay, I'm feeling a little emotional right now, but my name's Linda. I was diagnosed the end of July, beginning of August, I don't remember the exact date, of lung cancer, 3B non-small cell, same as you. Three tumors. I had radiation, chemo. Then I was able to have the surgery done in December, and there's no trace of cancer now. But they did the surgery. I thought you'd be happy to hear this. And I go for my first scan in June. So every 6 months I have to go. So that's that story.
Yeah.
My name's Jim. I'm with the Lung Cancer Foundation of America. We are one of a number of lung cancer patient advocacy organizations that are honored to be your guests here this evening.
I'm Kim Norris. I'm the president and co-founder of the Lung Cancer Foundation of America, and always thrilled to be here with the Addario Foundation. I think what they do in support of patients is amazing. I am a lung cancer widow of 15 years, and I only wish there were organizations like this back 15 years ago when my husband had it.
Thanks, Kim.
My name's Doug, and
Uh-oh.
not on. Okay. And I was diagnosed in July of last year with stage 4 non-small cell adenocarcinoma, EGFR positive, and I've been on Tarceva since. The tumors are asleep, my doctor said.
That's great.
Hi, my name is Larry Watanabe. I was diagnosed with small cell lung cancer. Kind of a rarity in this crowd, it seems like. But at any rate, I'm back in July, and I've completed my chemo, and that went okay. And then I've gone through my radiation, which is 10 days straight of mind and then lung tissue. And they just put me on I finished all my chemo and radiation. That's maybe 3 weeks ago, but they did start me last week on this new targeted gene therapy, or I guess this chemotherapy. And I'm really excited about it. Evidently, it's brand new on the market. Sutent is the name. I don't know if it's generic or exactly what. But a lot of people are starting to rave about it, and but it's brand new on the market, and so can't be more tickled. So that's about it.
Okay, Hildy. Uh-oh. Is it?
My name is Hildy Grossman. I'm president and founder of Stage Lung Cancer. I'm also a lung cancer survivor. That's the hope. So that was November of 2006. And we had an organization, as I said, Stage Lung Cancer. We use music and musical events to raise awareness and help try to balance. I was thinking of like Mary Poppins, a spoonful of sugar makes the medicine go down. People don't want to talk about lung cancer for the most part, except this great group. So, thank you. It's a good thing I have a loud voice, right? So I'm also a singer, and our organization uses music, and we just partnered with the Addarios a couple of months ago and did a program in Boston called Sing Out. And it was young people for the most part. All of the performers were young performers, and all the money will go to support the Young Lung Project. So that's it. Hope. Yes. Got to have hope.
My name is Cindy Langhorn, and I'm from the Caring Ambassadors Lung Cancer Program. I have been a patient advocate since 1998, and it's a pleasure to be with here tonight.
My name is Susan Levin. I'm president and founder of Lung Cancer Circle of Hope. We're based on the East Coast. We do educational programming. We're here because of a LungCan meeting, and I'd like to thank the Addario Foundation and Alchemy for being our very, very gracious hosts, and to all of you for being here tonight.
My name is Ellen. I found out 2 weeks ago that I have stage 4, what they think, on both sides, lung cancer. I don't know what mutation or half the stuff you guys are talking about, obviously, because I'm just new to all this. But thank the organization for having this kind of group together. Start chemo on Friday, so it's the first time, and I'll find out what that's like.
Hi, my name is Wynn Burkle. I'm an oncology social worker with an organization called Cancer Care, and we provide counseling, education, financial assistance for all diagnoses of cancer. I happen to be their National Lung Cancer Program Coordinator. I just wanted to mention that I met Bonnie, I think, back in about 2008 when she assembled about 200 of the best names in thoracic oncology in Fairmont, and she basically locked the doors and said, no one gets out until you answer the question, if money was no object, how would you cure lung cancer? And I bet she's still working on it now. Thank you.
Thanks, Lynn.
My name is Heather Hooper. I'm the Executive Director of the Lung Cancer Initiative of North Carolina. And our mission is to decrease lung cancer deaths, and we support patients and their families in North Carolina through our research, education, awareness, and access programs, and we're just honored to be here tonight.
Hello, my name is Hope Arnold, and I have a business called Hope Assistance. I provide personal assistance services to cancer patients, and I come to these meetings to learn and gain more information to be able to help my clients. My husband had adenocarcinoma in 2011, and out of my experience helping him is how I created my business. Thanks.
Hi, I'm Lisa Spain with Roxana's Foundation for Fighting Lung Cancer, and I'm the executive director. And I was a caregiver of Roxana, who passed away of lung cancer 8 years ago. And again, I'm like the others. It's so awesome to be in a place where cancer patients are supported, because I can remember being absolutely clueless to be a caregiver for someone. So, and my grandmother also survived lung cancer and is still thriving. So I am thrilled to be here and appreciative of everything that Bonnie and her team does.
Hi, my name is Gloria Leonards, and I am president and founder of Citizens for Radioactive Radon Reduction. My husband died in 2006 with lung cancer. We were living with high levels of radon, so I devote my life to educating people about the danger of radioactive radon gas exposure.
Hi, I'm Lawrence. I'm the one of the caregivers for my mom, Lily Lee. She has 4 kids, and last month I was trying to convince her to come down. So here she is in person. It's San Francisco, so it is pretty far for her. She got diagnosed in July with stage 4 adenocarcinoma, and we've had chemotherapy several rounds, and now she's on maintenance with the Avastin and Limta, and it's really nice to be here.
Hi, my name is Susie Roselle. I was diagnosed in November with adenocarcinoma, EGFR positive. So I've been on Tarceva, and I just started Avastin maybe 2 or 3 months ago. And my last scan was really good, and I only have 2 tumors left, and the doctor says my cancer is asleep.
You guys are hiding back here. Yeah, I'm hiding. Hi, I'm Deborah Morosini. I'm a friend of the family, and I was initiated into lung cancer when I lost my sister, Dana Reeve, to lung cancer.
And I currently am at Foundation Medicine, so I see a lot of my friends and have fun. Say hi to my pals when you're there this week. And I'm super happy to be here.
Thank you. Well, I'm Chris Draft, founder of the Chris Draft Family Foundation. We launched our Team Draft initiative, which is committed to changing the face of lung cancer with my wife, who was diagnosed with lung cancer in December of 2010 and unfortunately passed in December of 2011. So our commitment from that time has been to change the face of lung cancer, because we know that, you know, people don't fight for numbers, they fight for people.
Hello, I'm Carly Ornstein. I'm the Director of Lung Cancer Education at the American Lung Association. Also, my father is a stage 4 lung cancer survivor. He had small cell and non-small cell, because 2 is better than 1, right? And he's doing really well. So I devote my professional life to helping lung cancer patients, and I'm really honored to be in the presence of all of you. Thank you.
Hello, everyone. Thank you again for having us join you today. My name is Amy O'Rourke, and I'm with a Respiratory Health Association based in metropolitan Chicago. We've been a public health leader in metropolitan Chicago since 1906, fighting lung disease and promoting healthy lungs through advocacy, education, and community-based research. So again, thank you for having us today, and I look forward to participating in the conversation.
Hi, my name is Kimberly Lester. I'm with the Dusty Joy Foundation. We mainly focus on raising awareness, compassion, education for early detection, compassion for those touched by lung cancer, and we think Bonnie Addario is the bee's knees. So.
Hi, I'm Deb Violet. I'm founder, president, and CEO of Free Me from Lung Cancer. I was diagnosed with stage 3 lung cancer and was given a 10% chance of living 2 years. I celebrated 17-year anniversary this month. Thank you. I am humbled and honored to be here to and hope that I can give some ray of hope and inspiration for all of you folks. And I too want to echo Bonnie Addario is probably my inspiration and hero. She's done so much for lung cancer patients that goes without saying. Thanks.
Hi, I'm Dusty Donaldson with the Dusty Joy Foundation, and I'll be 10-year survivor in September. And yeah, go Bonnie. We love Bonnie and her family. Thank you.
Is everybody good? Oh, Deborah, yeah. I think the people that passed were people that didn't want to talk, and that's okay. Maybe next month. Thank you, everybody, for sharing your stories, and everybody from LungCan for introducing yourselves. I think it's so important to to show a united front for all of us, for all the many, way too many patients that are diagnosed every year with this disease. All of us working together is one of our happiest things. So, is Mom on? Did she say?
I haven't seen Mom online, but I would like to mention one of our supporters.
Sure.
This is on.
Yeah.
So we always like to mention our unique and very special supporters. And there is a young boy named Ellis who sent us in a check for, I got the right amount, hold on one second. I think it was $319. He raised the money by selling glow-in-the-dark bracelets. The awesome thing about Ellis is he has a speech impediment, and he made a sign, kind of like a sandwich board, to let everybody know why he was raising money and what it's gonna, go to support. So that always warms our heart and makes us feel better that there is a lot more advocates in the making. So I just want to give him a shout out.
Thank you. Shout out to Ellis. Thanks. Okay, so with that, I think we're going to get started on our program. Like I said earlier, Dr. Ray and Dr. Robbins, one of the things I don't think I said was that they are one of our designated center of excellence. So, you know, everybody heard around the room all this talk about Bonnie and her. You know, there's no way she'd put her name on anything that she didn't believe in 110%, and that is the truth. So we couldn't be more proud to be partnered with Baptist Hospital, which is a hospital within the Baptist Health System. They are in Memphis, Tennessee, and they are doing amazing things out there. So with that, I think we're just going to jump right to it, as usual, and this goes for all LungCan too. It's open floor Q&A as we're having this, so feel free to jump in. Hopefully everybody's mics are working now. And with that, I think the way we sort of formulated this is we're going to start with questions. The first couple are for both of you, and then we have some more specific questions based on your specialties. But the very first question, which I think is an important one to ask, is why is multidisciplinary care so important to the cancer patient?
Since you started it, Well, everybody here who's personally experienced directly or indirectly the journey of finding out that there is a problem, dealing with it, and then coming out at the other end knows several things. One, it is bad news, imminent threat of death, lots of doctors involved, lots of confusion involved, a lot of stress, a lot of doctor visits, and at the end, you get so many different inputs, it gets confusing about what is the right thing to do and what is he telling me? How can I trust what's being said? So one of the things we know about lung cancer is it's complicated. Lots of patients. Every year in the United States, 230,000 people diagnosed. Lots of doctors involved. A lot of delays in care. Patients have lots of additional burdens with their health that come on with age and with tobacco use, heart disease, strokes, other cancers. A lot of our patients have actually already survived the previous cancer. And then you have the problem that the cancer is in almost the most inaccessible part of the human anatomy. I guess the only other place more difficult would be the brain. So in the chest, you have this rib cage, you've got the spine, you've got these two lungs, inflated balloons, you've got this heart and blood vessels daring somebody to make an error and stick something in there where it doesn't belong. So what you find is doctors are worried about getting at the place where the problem might be, and patients are frail. And so what you wind up with is a sense of nihilism. Well, bad cancer, probably going to die anyway. What are we trying to do here? So what we said is that doesn't work. If we're going to make things better, we definitely have to start out by improving the quality of care that patients get. And the way you're going to do it is you're going to have to simplify things. You're going to have to bring, rather than the patient to the doctor, you're going to have to bring the doctors together to surround the one patient and then have these guys crossfire among themselves and then figure out what the right thing is for this one individual sitting in their midst today, rather than, well, I think this is what you need because this is what I know or what I've done before. And then somebody else says this is what you need because we think. And then at the end of the day, we're not sure whether you've had the right care. So all the experts agree that lung cancer care needs to be delivered in this multidisciplinary fashion. Patients love it. It's a simple way to do it. One-stop shop is what we've been told by our patients. But if you look around the country, you don't see too many examples of this model being executed. So the challenge that Todd and I decided we wanted to take on several years ago was we wanted to implement a rigorously benchmarked, clearly functioning multi-D program in a chaotic community healthcare environment. That was the challenge, and that was the reason why we took it on. Todd, anything else? Well, I'd just echo what Neil said earlier.
there's a lot of people from places around Memphis, like Greasy Slough, Arkansas, that they're going to come to town one time. They're not going to be able to get somebody to bring them to town 5 times. And what the statistics are and what the numbers are is from the time of your chest x-ray to the time of actually making a definitive move is somewhere around 3 months nationally. And what we're trying to do is enable that person to come one time, get a decision, not by amateurs, by experts in the field, and then move forward quickly. And it makes a difference.
So on that, why do you, well, not why do you, first of all, do you think there's pushback in the community setting, in this, the typical community setting, I'm not talking about Baptist in Memphis, to this approach, to multidisciplinary care? And if you do think there is pushback or resistance, why?
Yeah, so the first observation, of course, is all the experts, all the professional organizations that are engaged in lung cancer care unanimously recommend multidisciplinary care as the optimal model of care. But if you turn around and look across the land and ask where exactly is multi-D care being implemented, very precious few examples will you find. So there's a gap between what the so-called experts say ought to be and what is. Clearly, there is a problem. So we took on this task knowing that there had to be a problem, but we didn't want to assume we knew why the problem was. So we said we would implement our program, but we would also study it so we could learn, and then from what we learn, maybe we can teach others. So we decided to write a grant. And we said we would structure our grant into 3 bits. The first part would be to identify key stakeholders and then find out from them what their perceptions of current care delivery for lung cancer was, what they think about the 2 different models of care, what we call the multi-D care model and the serial care model, which is this sequential referral from doctor to doctor and so on. And we wanted to learn from them also what, from their perspective, if you were going to compare these 2 models, you had to see one model do better than the other for you to be convinced it was truly superior. And then also we wanted to learn from them what, from your perspective, are the barriers to actually doing this. And the stakeholders we had were patients, of course, their caregivers, the various doctors, and we split doctor groups into 2. We had primary care doctors, emergency room doctors, hospitalists, the kinds of doctors who typically order the X-ray or CAT scan that leads to the first identification of a lesion. And then we had the other doctor groups, the specialty doctors who have some skin in the game in terms of having some expertise. So thoracic surgeons, medical oncologists, radiation oncologists, pulmonologists, nurses as well. We also had hospital executives, the people who provide the environment of care, and third-party payer executives, insurance company executives, the people who actually have to pay for the care. And what we wanted to do was learn from them. What are the obstacles? Why would this work? Why would it not work? What do you think is good or bad about this? And we learned a lot. From patients, we learned that this is a great idea. This is what they want. Why did nobody do this when I really needed it at the time? Family members taught us things like, well, you know, when I have to take my wife from doctor to doctor to doctor, that's several days of work lost. Whereas if I could go and get it all done once, I would spend a whole day, miss 1 day of work, but then it's not as bad as in the other model. So patients on one side loved it. When we talk to doctors, there's several things they tell you. Well, I think I can take care of lung cancer as well as anybody else, is one thing. But then you say, yeah, that's true, maybe, but what else, what else? And then they tell you things like, well, I don't want to lose control of my patients. Or, well, you know, I'm used to referring my patients to that doctor. You're coming in wanting to disrupt that relationship. I don't want to lose the ability to tell the patient what is best for them. Others tell you things like, well, if something goes wrong, who's going to be responsible? Other people tell you things like, Well, what if I don't agree with the recommendations of the Multi-D program? Are you going to impose the collective will on me? You're threatening my physician autonomy. So there are aspects of this. There are financial issues. There are control issues. There are legitimate concerns about maybe the social, the medical legal consequences of this uncomfortable, strange model of care. You know, so the doctors want the good thing, the right things for their patients, but there are hidden barriers that we've been able to bring out in the open. And then as we have learned about these barriers, we've been able to structure our program in such a way that it recognizes these issues. So for example, one thing we learned is that it is death. It is absolute death to have a patient come from a doctor and somehow mix things up and not recognize that you have to keep that doctor tightly in the loop about every decision that you make. It is also maybe not very smart to have a patient come in and you have a decision made and you have a doctor who already has a relationship with the patient and then wrench that relationship. We're learning that we have to respect antecedent relationships as much as possible. So these are some of the things that we've learned about obstacles and how to get around them.
So it's interesting, and I think from speaking from the patient perspective, and if anybody has a comment, please chime in. I think that there's everything you said is really important, right? Identifying those barriers and doing the studies and talking to the right people. But I think if you ask a patient, particularly when it comes to you know, their treating physician, and if they're the patient who's going to come in and say, well, my doctor should have done this, and why didn't he do that? Because I found out later, and it was because another doctor didn't want to disrespect this doctor. The patient's like, really? And I feel like it's coming from a place where, I mean, Liz, do you care if your doctor is going to be disrespectful? And I understand professional courtesy, I do. But in lung cancer particularly, when patients are diagnosed so late in the game, more often than not, it's important, I think, from a patient perspective, that what's best for the patient comes first, right? So, and that's a challenge in and of itself.
Absolutely. From a selfish patient's perspective, I want an expert who has the latest innovations in mind to be optimizing my care, to be doing as much as I can, especially in my circumstance, being young, recently married. I wanted a physician that was willing to go onto the bleeding edge and be a partner with me with that. And I did that with a second opinion, and that was really wonderful to be able to triangulate, because physicians sometimes have their comfort zones and they get used to treating a certain way or approaching a certain way, and they have their biases. And as you well know, there are very different treatment methodologies all throughout the country. And coming from the biotech world, I want to understand. I always like to triangulate and figure out, okay, what do different people from different perspectives think about my case? And for instance, my oncologist up at UC Davis said, let's do a Hail Mary. I think I've seen your disease before, which is rare. I think we'll try this, and we'll know it in a month or two. And that's what I wanted to know, versus having a physician who was willing, who wanted to play it safe, because that's what the clinical trials said. And coming from that field, you know that clinical trials for the information to be published sometimes takes up to 10 years. Well, that's just light years behind from where I want to be. I want to be clinical. This is first clinical trial 1, 2, 3, phase 1. If something's looking really great, like if something's getting 80 or 90%, for instance, even if it's a very small population, I want to at least have the discussion.
Right.
And for my oncologist to say, these are the pros and the cons about it. And I think, honestly, if a physician if they have an issue with another physician coming in and honestly giving their opinion as to what is in my best interest, then maybe I shouldn't be with that physician. If they're taking it personally and their ego's getting involved, quite honestly, this is not about their ego. This is about my life.
And I think that you know, in looking at, and I guess I want both of your opinions on this, and looking at, you know, the last decade, say, in cancer and the advances that are being made, and, you know, 5 years ago it was personalized medicine, and now it's precision medicine, and, you know, the buzzwords keep changing, but the game is the same. Do you see a future in, and I've asked this question before, do you see a future in oncology in specializing, right? Things are happening so fast and so furiously across the state of oncology.
Well, just to speak to what I do, I was a heart surgeon up until 3 years ago. We did heart and thoracic, and they basically have totally split apart now. I was doing minimally invasive thoracic surgery, one of the few people in our part of the country, so I went and started the robotic surgery, and the volume built up so quickly I had to drop cardiac surgery 3 years ago. But it was a decision to make, and I think it is absolutely incumbent upon anyone who has lung cancer to go to somebody who only does that. I think it's becoming true in medical oncology too. I think there's generalists out there that treat breast cancer, colon cancer. Personally, I want somebody like Ray who spends 95% of his time doing lung cancer because he's more up to speed on what happens. And to what you said, change is tough for everybody, and it's especially tough for doctors. And once you've been in practice for 15, 20, 25 years, you tend to see everything through one prism. And it's hard to break out of that. And what this multidisciplinary clinic does is it brings in people. We have a conference before the clinic every Wednesday, and many oncologists come in from outside, and it's amazing some of their ideas about lung cancer, and these are good oncologists. And Ray and I just kind of look at each other and go, where did you get that? Mm-hmm. But we're changing them slowly, but it's still, you can tell it's hard to get them out of that shell.
Yeah.
So you can't drop a bomb and nuke everybody, right? Because you don't like the so you have to, it's not what you say, but how you say it is one of the key things that we try to remind ourselves. Yeah. So you may have a disagreement with somebody, but you can't just, you know, come out with a knife and say, I'm going to cut out that idea from your brain. You have to find ways to work with people. But you're absolutely right. Everything starts and ends with the patient, and we must never forget that. And I think where the patient's interest is being overridden by other interests, I think is where a multi-D environment really gives you tremendous value, because what you suddenly have is sunshine. You have different specialists with their different opinions, and then you have a patient. And now you have to have evidence and agreement. So one of the major benchmarks of our program is that at the end of every discussion, there has to be a clear consensus that's evidence-based. And then after that, we come back to ensure that whatever we said was a consensus recommendation gets done. And if it is not done, we want to know why it was not done. So this issue of a concordance rate is something that's tremendously important to us, because we have shown in a previous life that, yeah, the doctors they come around, they talk, and then you go back 6 months later to find out just what's been done, and half of the time it seemed something entirely different had been done when that sunshine was no longer there. So one of the key things that we have learned is you have to communicate, and then you have to follow up to make sure the right thing gets done.
But also, there's more than one way to skin the cat. And many times, and I think especially in your situation, I'm not sure what you were originally going to do was wrong. You just wanted something different than your oncologist was going to do. That doesn't make your first oncologist an idiot, and it doesn't make him wrong. It just means you wanted something different. But you're an extraordinarily unusual patient. Most patients come in, you tell them you're going to cut their head off, turn it around, they go, yeah, doc, let's do it. Mm-hmm. And it's a huge responsibility to tell patients what they need and to be confident that you're correct.
Yeah. And I think one of the challenges there, too, is there's not any set way to treat this disease, right? It's not like you can go to a book that says this is what they're diagnosed with. Even this is their molecular makeup at diagnosis, and this is what you do. I mean,
but more and more we're beginning to know the right way. You know, we're now, so one of the benchmarks that we have, for example, is stage confirmation rates. It sounds very simple. How frequently did you actually go and take a biopsy to confirm the stage that you're going to base your treatment on? It sounds very fundamental. It turns out in over 90% of the time in the United States, over 90% of the time, at least in the most recent data that we have from Sierra analysis, that's not done. And when you correlate between those in whom stage was truly histologically confirmed and those in whom it was not, there's a huge difference in survival.
Well, even in early stage, right, when it comes to post-surgical restaging, right?
What one of Ray's really big home runs in our field is sampling lymph nodes at surgery. And what we've found is if we sample nodes in a systematic way, that we upstage about 15 to 20% of the patients from where we thought they were. So that means a patient that you told was cured, 20% of those, if you haven't sampled lymph nodes, actually have positive nodes and need chemotherapy to increase their survival. But you don't know that because, I don't know, Ray, you know the percentage. What percentage of people systematically sample nodes in the country?
Oh my goodness, it's less than 50%.
So 50% of the surgery done in this country is inadequately examining the lymph nodes. And of that 50% of those patients, 20% of them are going to be understaged and not get the therapy they need. So these are, they sound like small things, they're huge.
Well, they're huge things, and it kind of goes back again to what we just said a moment ago about, you know, at one point in your career you were cardiothoracic, right? And now that you're completely doing lung surgeries, right?
Well, and
now you know this, but when you look, or maybe you knew it before, I'm not making assumptions, but in the community.
We're all human, and if I've got a mitral valve and a valve cabbage in the afternoon, I'm doing a lung in the morning, I'm kind of moving on through that case pretty quickly to get to my next two cases. When you drop the cardiac out of it and your total focus is on the patient you have that morning, and I do more than one lung case a day, but you concentrate on one thing a lot better.
It's just the data points back to another challenge in the community, right? And people knowing
and that's
that
a huge challenge we probably
this is what we need to do. Yeah.
So Bonnie's online, and of course she made a statement or well, a statement, but I believe that if she didn't believe this 11 years ago, she wouldn't be here. When Bonnie, our mom, was diagnosed, she was basically said, this is kind of like, we're going to cut your head off, turn it around, and that's how we're going to do it. But she refused that, and she says, you know, shared decision-making between physician and a patient is a must. And whether it's an academic center or a community hospital, it's just an absolute must. But we need to educate the patient first, and prior to them being a patient. So Bonnie's very excited to be online too, by the way.
To create awareness around the disease, and I think she'll agree, and you'll agree, and the rest of the staff in the room. We sort of take this top-down, bottom approach top-down, bottom-up approach to what we do, right? So not only working with the thought leaders in the space and the guys that are really, you know, truly 110% doing lung and doing it well, but by educating the patients out in the community so they can go back to their docs and say, well, you know, so-and-so told me to ask you whether or not this was an option, you know? So I think it kind of goes both ways.
You know, if I could, you know, add to that, both of the doctors have alluded to the patient who comes from Arkansas, maybe comes once in 3 months, or they have to go to different places. So now they come to the place, wherever it is. And I'm wondering, because I've heard it from a number of patients throughout the country, how long from the time they were diagnosed till they got more specifics. So maybe they had a biopsy done. You know, I was very lucky. Personally, my doctor was a pulmonologist, so he was right up to date, and he ordered it right away. And it seemed like forever between that time when the interventional pulmonologist took some out. I told him he could take out as much as he wanted. Why stop? You know, I didn't realize, why couldn't he take it all out right then? Pull it out. Didn't work that way. But I wonder, you know, because I've talked about and been with different people who are working on blood biopsies So when that person comes in your office, or they're in Cozad, Nebraska, and the lab there takes blood and sends it somewhere, how far away are we from when you see the person or get the information that we can say with pretty good certainty, because you have EGFR positive, then you should be on Tarceva, the majority of cases, or that there. Is it 3 months before they have to come back, find out that information? Now they've gone 3 more months with some mutations perhaps, some more growth. We've missed that time. Their symptoms have gotten worse, et cetera. So where are we with that in your hospitals, but where are we with that throughout the country?
We just spent 3 hours last night talking about this.
Yeah. So yesterday, so as part of our project, we've got this group out of the University of Wisconsin-Madison's College of Engineering in the industrial engineering department, who are actually working with us on process engineering, how to flow patients from beginning through the various steps that you have to go to get maximal efficiencies. It's very interesting. Lung cancer is unique in the sense that the first shot gets fired always with an abnormal X-ray. So you can actually, if you're careful enough, persistent enough, you can actually go back to identify exactly when the first abnormality was present, okay, was identifiable, I guess I should say, whether it was actually recognized or not. And then you have these steps in between. You have an abnormal chest X-ray leading to a CAT scan, and then you have a need for a biopsy, then you have a need for a staging test, usually a radiology, like a PET scan, a brain MRI. You have a need for a staging biopsy, ideally, such as an EBUS, endobronchial ultrasound-guided biopsy, or mediastinoscopy, and then treatment, theoretically, okay? So we've got these nodal points. So we were very interested, and a little artificial. Sometimes you combine these things, or you skip a step, or something. But we were interested in breaking this down into its granular steps so that we could then measure how long it takes to go from one to another, and what percentage of patients go through some of these steps, and also to see how that flow of care leads ultimately to a start of treatment, whether it's surgery, chemotherapy, radiation, or some combination. And the results are striking. If you just ask from what is the median time, the halfway mark for a group of patients to go from when that first abnormal X-ray is had to when treatment begins, it is an interesting number. It's about 86 days.
3 months.
And that's the median. So if you take the 25th and 75th percentile, the 75th percentile is actually 6 months, meaning that 25%, 1 in 4 patients, go longer than 6 months from when their X-ray is done that shows a lesion that could be a cancer to when they actually start treatment.
And our statistician told us that, and I was horrified. And the guy said, well, actually, we're a little better than everybody else in the country. We're actually, that 3 months is actually pretty good when you compare it to everyone else. That's how bad it is.
Mm-hmm. Yeah, so we said, obviously, this, you have to do something better. So we started doing probability computation, where you start looking at which pathway seems to lead you faster and where are the bottlenecks. So we did something called the bottleneck. This guy, Dr. Lee, is a professor of engineering at the university. He actually used to work for GM. He worked there for about 7 years. So it's that kind of mindset you actually have to bring. Interestingly, in healthcare, although it's a $2.7 trillion part of our economy, that kind of fundamental analysis has never been done, apparently. Just trying to say, okay, let us get past emotion, practice, culture, knowledge, wisdom, handed, received, or whatever. Let's actually look at the data, at our practice data. How do we flow from step to step? And that's kind of where we are now. And then when you throw in the issue of needing to do tests that you don't have in-house, such as mutation tests, then you have an additional problem that you also have to identify, quantify, and then where you're not satisfied with it, figure out a way to make it shorter. In general, to get a mutation, so we use a lot of next generation testing with Foundation Medicine. It takes about 2 to 3 weeks to get the result back. Now, there are a few steps in there, of course. You have you place the request, and then the paperwork gets filled out, and then they have to go and get the material from the pathology department, so that puts in a few days there. So the way we handle it with patients is, if we have a patient who's looking and feeling well, and who we really feel probably is a dead ringer for a mutation, we actually, if the patient is willing and comfortable, we actually encourage them to wait a little bit. Let's get this result back. Because, you know, if I can put you on a pill and have you take it once a day at home, why would I want to bring you in to take chemotherapy every 3 weeks in my clinic, right? On the other hand, if I have somebody who's really symptomatic and we don't really feel like we can wait the 2-3 weeks, then we start them on chemotherapy, and then when we get the result back, we use that, we factor that in, offer that to the patient. Look, do you want to stop this now and go this way, or what do you want to do? Interestingly, some patients say, well, chemotherapy is working, don't change it yet. And most others say, well, yeah, let's switch right away.
Either way, yeah. Go ahead, Liz.
Quick question. You talked about the X-ray showing a suspicious lesion or something like that as kind of your starting point. And I think there are a number of patients here, especially some of us that are been around here a little longer, that the time from when we have something happen that makes us go see the doctor for the first time, and until that X-ray is done, I don't want to say often, but quite a lot seems to be an extraordinary long period of time. I'll give you an example in my circumstance. Never smoker, very healthy runner. I literally went almost a year from starting to have a strange cough and some things going on, and I literally went to 3 different general practitioners. First I was told, oh, you have allergies, you know, oh, it might be some type of infection. Then I was told I had acid reflux, on and on and on, until I finally got to the 3rd GP, and I said, look, I'm not a hypochondriac. I think there's something going on. I thought maybe because I grew up in the country that I had that pneumonia, I mean the bacterium or something like that. And I said, work with me through this. Only at that time did someone finally do an X-ray. How can experts like yourself help change that paradigm to help the general practitioners and those that are out there in the community to at least start, at least at very minimum, if they try throwing an antibiotic and the patient doesn't respond, at least do the X-ray. Do it more quickly versus waiting 9 months to a year. And I know there are a number of people that I'm speaking for as well in this room that have gone through the same experience, because I hear time and again from patients that I'm meeting here or in other circumstances saying, I was stage 4 and I was having issues a year ago. Why did it take so long?
It's a big, that's a huge point. You just threw in a little extra time in there that I didn't talk about, which is the time from symptom onset to actual radiologic detection. So for our program, what we did was said we wanted to try to improve the quality of care in our environment. We said we wanted to start with what we can objectively quantify, which is that X-ray. But absolutely right. With the symptom, there are actually 2 components there. There is the time the patient developed their symptom and then recognize finally a need to go seek help. So there's some patient-induced delay. And then there's the time from when the patient seeks that help to when the doctor actually takes the ultimately correct steps to lead to a cancer diagnosis. Now, BAC is tricky because oftentimes it looks like pneumonia. So you could have had that chest X-ray and the doctor would have pumped you full of antibiotics for a good long time before ever acting on it. That also happens, unfortunately. So how do we do this? How do we approach this problem? I think you start out with awareness. There is still this idea that only smokers get lung cancer, okay? There is also this idea that, well, if it turns out to be lung cancer, the patient is not going to do well. So why hurry to figure that out? So there's a lot of nihilism on one hand. People don't want to think of that. And then on the other hand, there's the concern that well, this is a non-smoker. We're not even thinking of cancer. So I think awareness, a public awareness campaign, and maybe in there, for smokers at least, screening will help the awareness of the benefit of lung cancer screening. The availability of lung cancer screening for people who are eligible for that will also definitely help.
You can add to what you said about your time. Suppose you didn't have insurance. You might have waited another 6 months. Yep. I mean, that's a huge problem.
But doesn't insurance also keep doctors from doing some of these tests that they feel?
I can't find where it's coming from.
Oh, Sally, right here.
Not in our clinic, it doesn't. We accept anyone regardless. But yes, you're correct.
Well, no, I don't mean whether they have insurance, but whether the insurance companies want the doctors to be doing this. That's what how much does that influence?
I can't say we've ever had too much pushback on
So
that. A little bit, but not if we insist. I really have not seen that.
There is a link there in the sense that where I'm thinking, departing from with that question is, I told you about the precious real estate within which lung cancer resides. It's a hard place to get at, okay? There is the risk of really hurting people, okay? So for example, one of the big fears that we have about successful screening in real-world environments is most people who have a lesion in the lung don't have lung cancer. In fact, in the NLST, it was barely 4% of lesions that turned out to be cancer. So 96 not cancer. So if you can imagine, if you're jumping on 96 patients out of every 100 erroneously, doing all kinds of invasive procedures on them, and it turns out they don't have lung cancer, each procedure has its own risk rate. And so you run the risk of harming people. So when insurance companies, when doctors, when society even comes out and says, well, don't automatically treat everybody the same. You still have to have some algorithm that you use to triage patients. There is a need for that. There's safety involved in that as well. When we start out with the answer, a group of people diagnosed with lung cancer, and then winding back to the beginning, what we leave out are all those people who were thought to have lung cancer because it looked like it, but didn't have it. And some of those people may well have had a biopsy or some procedure that harmed them. So there's some balance in there. And trying to navigate that, in all fairness, is hard. Which is why, once again, you don't need somebody in a silo trying to imagine the right thing to do. You need to. How many times, Todd, do we see in the clinic or the conference where we're like, yeah, this one looks so, and the radiologist says, no, this is a histoplasma, leave it alone, or if, repeat it in 3 months, and they turn out to be right. So there's a need to get multiple input, and the thing about multi-D is to get it at the same time, so that it's not one person's wisdom, but it's the collective knowledge of experts.
Just to explain what we do, we have a conference before the clinic where we go through all the films and all the patients' histories. We have 4 oncologists, 2 dedicated thoracic surgeons, a radiologist, a pathologist, and then 4 or 5 personnel that do all the data gathering and stuff. So we pretty much grind through who's going to need a procedure and who isn't. And I'd say, really on the lung nodules, probably only 15 to 20%. And these are already pre-selected to be high, what were considered by their referral doctor to be a pretty significant nodule. So that's what gives value to a multi-D approach, is all of these eyes on one case at the same time. And quite often radiologists will go, well, did you notice this over here? And Ray and I go, no, I didn't notice that over there. And that'll change the whole way, the pathway that we're going on. So that's why it's important to have lots of intelligent people in the same room.
So when you go back to a patient and say, well, after tumor border conference, you know, we've decided that we're going to watch and wait or whatever. Is the option ever given back to the patient saying, we think you should watch and wait, but, and I ask this because I get calls from people all the time. They're telling me to watch and wait. I don't want to watch and wait. I don't want to watch and wait. Regardless of risk, I'm willing to take the risk to be able to sleep at night.
That's part of embedding the patient in the process. If the patient says, I understand you don't think this needs to be biopsied. My father died of lung cancer. I want it out. Ray and I will tell them what we think, and if they want it out, we say, you're on the schedule tomorrow.
So that's where the patient education comes. Athena, hang on one second, because Susan, I think, was right before you, and then we'll go to you, and then I think we have some online questions.
As a patient advocate, I would say to a patient that has a doctor who balks at a second opinion, find another doctor. However, I think of my late mother, and she was embarrassed by me. And is there a way, or are there words or that someone of a certain age who thinks that, you know, with all due respect, that, you know, doctors are gods, are there words in which someone can request from their medical oncologist? Because I get this question all the time. You know, how do you diplomatically ask your oncologist or pulmonologist?
If a patient tells me they want to go to the Mayo Clinic, I said, let me get you the phone number. Please go to the Mayo Clinic. If you're that uncomfortable, you need a second opinion.
So one of the things we have to emphasize always is it's not about the doctor, okay? It's not about the doctor. It's about the patient. When I ran our fellowship program, I used to ask my fellows, what part of the economy do you think you exist in? And they would look at me. I said, you are in the service economy. That's what you are in. You don't manufacture anything, okay? You're just here to help people understand and get better about whatever problem that they have. So it's not about the doctor, it's about the patient, okay? In the Multi-D program, one of the things the feedback we got from our patients in our focus groups was exactly relating to second opinions. They said things like, I felt like in the Multi-D environment, I got a second, third, fourth opinion because all these doctors were surrounding me and talking about me at the same time.
That's why Bonnie has brought you here, but not everybody are like you guys. Is there a way that, you know, you can offer people who are out there and people I talk to all the time is to, you know, you want to stay with your doctor for whatever reason, but you want to not hurt their feelings?
It's not about the doctor.
No, I understand.
No, you need to let your patients, your friends, your network understand that, because honestly, that is the truth. The doctor would not exist if there was not a need for that service, meaning if there were no patients. So we need to help people understand that.
I understand what you're saying. There's a generation of people that have, unfortunately, they seem to be becoming less, that have a high respect for for doctors. And my father was a surgeon, and even he had that kind of opinion. He'd go to one of his friends and I'd say, Dad, your friend's not worth it. Plug Nicollet with this. I want to send you this young guy that just got back to town. He wasn't about to switch, and he knew what he was doing. I mean, it's understandable. I mean, but part of what he's saying is the patient's got to be comfortable too. I mean, if they're happy and they're doing that, then there's a value in that with that doctor. And you know, you can retrieve that situation at some point in time, probably. But I don't know that you need to rip people's faith in their doctors away from them because you're uncomfortable with it. I think that can be done a lot more subtly than that.
Well, a second opinion doesn't mean that original doctor refuses.
I agree, but what you're talking about is an age group that feels that a second opinion is an insult to the doctor.
And that happens all the time.
Yeah.
So I'll tell you, I tell my patients, okay, if your doctor is not happy with you getting a second opinion, fire your doctor. That's what you do.
But it's also one of those things that because caregivers, Susan, typically are the ones that, like, I can't get my husband, wife, parent, cousin to consider a second opinion, right? So what we will typically do is explain to them the important, your doctor could be the best doctor on the planet, but we're talking about lung cancer, you didn't sprain your ankle, right? So we feel like it's really important, but at the end of the day, all you can do is know that you tried the best to get, you know,
Exactly.
and it's up to the patient.
Yeah, I think exactly right. I think when you have explained to the patient, first of all, there is no issue here because we have to worry about you, not the doctor's feelings, okay? Second of all, if the doctor is not happy about it, he just showed you something wrong with himself, okay, not you. And third of all, this is a life-threatening problem. We need to, if there's ever any question, we need to be satisfied that at the time we made our decisions, we were comfortable with the decisions we made. If you have those three things and the patient says, well, I don't want to do it, well, there is the principle of patient autonomy. It's a fundamental underpinning of our healthcare, of our medical philosophy. You have to respect that.
Yep. So I have quite a few questions online. It's quite active tonight. But I'm going to start with one note, and it's what I hear Bonnie asking everybody. If this was your child, what would you do? And you would go and get second and third and fourth and fifth and sixth, as many opinions as you want. And she says, okay, well then why aren't you doing the same for yourself? In any disease, not just lung, but specifically young. So the first question was, do you feel that CT scans are invasive?
A CAT scan? No, in general, when we use the word invasive, we're talking about something piercing the skin going into the body. Yes, CT scans are not entirely without problems. There is some radiation exposure, but I think when you're doing them judiciously, so for example, the types of CT scans we do in a screening program, a low-dose CT scan, single breath holds, much less radiation, about the same as you get with a chest X-ray. So obviously, don't want a chest X-ray or a CT scan or anything if I don't need it. But if I need it, it's not something to quibble too much about, I think. So simple answer, invasiveness, no, that's not what we're thinking when we're talking about invasive. Maybe there's some invasion of privacy. They're telling you to put on a gown and this and that in a strange environment. But in terms of physical invasiveness, no, I don't think of that.
Okay, next question is, how does a patient, or how should a patient know that they're getting a multidisciplinary care?
Great question. You know, when we, Todd, you want to take this?
The answer seems so simple to me. It must be more complex than I think. Why don't you answer it?
So when we did our focus group of healthcare executives, they actually asked us that. They said, okay, well, yeah, if at the end of the day your multi-D comparative effectiveness trial works out showing multi-D is superior, we still got a problem. How are we going? What's going to stop anybody from slapping the term multi-D on his new name and then, you know, bingo, we've got it. Yeah. And we said, well, you have to have certain benchmarks, and that's part of what we're actually testing. So first thing first, who is in there? You can't have multi-D if it's 3 oncologists together and multi-D, okay? There are certain key specialties you have to have. You have to have a surgeon, okay? The presence of a surgeon is a vital part of any multi-D program. If you don't have a surgeon, you don't have a multi-D program. You know why? 90% of patients who will survive a lung cancer are people who have had surgery for it. Okay, so you gotta have that. You need pulmonologists. You need a radiologist. You need a medical oncologist. You need a radiation oncologist. You need a palliative care specialist, okay? You also need pathologists. These are the core specialties. And then you need a navigator. I cannot tell you enough the value of a navigator. It is such an important role. In our program, I have said, look, you can fire the rest of us, but Christy Rourke stays because she's our navigator and she's the one who makes it all happen together. So these are the components you have to have. So you don't have multi-D until you have the steady presence of these people. That's one. And then two, what they do is also important. So the benchmarks we have we have timeliness of care. How long does it take us to go from point A to B? We have our concordance rate. So how frequently do we actually do what we agree is the optimal thing for the patient? So in A multi-D, if you're saying one thing and doing something else. We also say we're interested in our stage confirmation rate. How often do we actually go, the lesion that is driving the stage upwards, how frequently do we go take a bite out of it to make sure it's truly what we think it is? And then we have our stage appropriate treatment rate. So for stage 1 and 2 patients, we feel you really ought to go to surgery, and if there's a good reason why you can't have surgery, you ought to have radiation therapy. For stage 4 patients, we say, well, you really ought to have systemic therapy, whether it's chemotherapy or targeted therapy if you have it available, or palliative end-of-life hospice care if that's what you desire or that what seems to be best for you. And then for stage 3 patients, we say you have to have a combination of modalities. So then each of these groups of stages, what percentage of patients go into them would be another benchmark for your multi-D. So you can't just say it's multi-D because I say so. It's multi-D because it hits each of these benchmarks.
I'd just add to that, Ray and I have been to several places to see what people were doing with multi-D, and most are not, and most are extremely famous places that everybody here knows about. And it's amazing how many people put it up on the door and do not do it. And the second thing I would ask is if you're going to have surgery done for a stage 1, stage 2, you need to have a minimally invasive surgeon. You do not need an open thoracotomy. The American College has decided that just last year. There's a lot of pushback from guys that don't want to do it. There's plenty of people doing it. Every community, just about of any size in the country, has someone. If you know somebody that's going to get an open thoracotomy, they need a second opinion for a minimally invasive thoracotomy.
Comment on that. I assume you're using the Da Vinci.
I use the Da Vinci, but the thoracoscopic thoracotomy is perfectly good too.
Okay. Well, what I was going to say is I was part of a group that went to visit Da Vinci and got to see how it worked and everything. And I was part of a group that was there for 3 days.
You went to Sunnyvale to see them? Really?
And I was the only one from a major urban area, a cosmopolitan, whatever you want to call it. There, we were all, turned out we were all stage 1. They had people from all over the United States. They all had robotic surgery. I was the only one in this area that it wasn't even a consideration. And I thought that was interesting. And here you've used this, and how much easier that type of surgery would be on a patient. Even the VAT surgery would have been
Most people go home in 2 days and on virtually no pain medicine.
Right.
No more scarlets going on that.
On that note, I just wanted to also say, how can we, like I had the traditional thoracotomy, and there wasn't any robotic surgery 10 years ago, and there was very few surgeons who were doing the VATS at that time. In North Carolina, Duke was doing it, but I was at a comprehensive cancer center, and I had traditional thoracotomy. I really want to emphasize to newly diagnosed lung cancer patients, like, don't go under the knife with the thoracic surgeon. All thoracic surgeons are not created equal, and but how can we reach that? Because even though there might be some span of time, I mean, we don't move in those circles with thoracic surgeons, and so what advice can you give us to help reach these people to get VATS at least, if not robotic surgery?
The numbers are 40%, only 40% of thoracic procedures in the country are done minimally invasively. I don't believe that. I think it's much like how many people are being seen by multi-D. A lot of guys say they're doing minimally invasive and they're not. So it's probably only somewhere around 30%. Now people will argue about that number. So 7 out of 10 are still being done open. And it's still a good operation. It's just a lot of operation. And once again, this really is all about the patients. And you know, it's a steep learning curve. It takes time. There's a lot of cussing. There's a lot of being miserable. There's a lot of spending extra time in the operating room. But you just have to take the time to learn how to do it. I go around teaching people to do it, and there's a lot of people that I teach that don't need to be doing it because they just do not have the right. And there's nothing spectacular about doing it. It just takes a mindset that's a certain type. And some people don't need to be doing it. Some people should be doing it. Now, where the patients fit in there is going to be difficult. You know, in small town America, many thoracic surgeons will do, or also the heart surgeon will do, well, you do the 10 cases a year, 5, 6, 7 cases a year, open thoracotomies.
Yeah.
That's not enough to be doing minimally invasive work. You need to be doing, I mean, I do 300 a year, and you know, there's grades in between. Tommy D'Amico over at Duke probably does 500 a year. I mean, there's you need a big center with a minimally invasive surgeon. But that being said, there's a lot of people that are getting really good work in small towns that don't want to travel 150 miles to have the thoracotomy done.
So in essence, the core of the Centers of Excellence program that we started at the Addario Lung Cancer Foundation is just what he said. We know we're not going to have 4,000 community hospitals around the country practicing multi-D care. But if we can get 60 or 70 or 80 and get people within a 2 or 3 or 4 mile, for a 2 or 3 or 4 hour driving radius to those centers, we know that we can change the impact and the care that those patients are getting and increase the survival rates for lung cancer. And that's the ultimate goal. And why we chose Baptist in Memphis is, although they're sitting really far apart on that couch, and I'm not really sure why, what you have seen tonight is a team approach, and we've been there. We've visited these hospitals. Danielle and Andre and I spend our time traveling around the country identifying hospitals like Baptist that are doing what's right for patients, and that's giving them the multi-D care. And this is why we brought this in the room tonight, and I don't think there's a patient in the room, and I don't think there's an organization in the room that would disagree with what we're trying to do here. It's the right thing because it's the right thing for patients. And you both have said that more than once. It's good for patients, and that's what we believe.
Well,
so
I couldn't
it's
agree.
the essence of what we're trying to do.
And I couldn't agree with you more. And it's always at the end of, whenever we're looking at hospitals for Center of Excellence designation, it's conference calls and whatnot, but it always ends with a site visit and a sit down. It's like you're telling us you have a multi-D team, and I want to see your multi-D team, right? And so we get to sit down with all of them because of exactly what you just said, Dr. Robbins, that half the time they say they do, and then you get there and it's not the case.
Is the patient present during those?
Yeah. Yes, so that's a huge component. So in a previous life, we ran this conference-only model of multi-D. I was at the University of Tennessee in Memphis. And after a number of years, I went back and reviewed all the patients that we discussed over 3-4 years and looked at the outcome. And we published a paper, Causes and Consequences of Deviation from Multidisciplinary Care. So basically, we had these patients. About 40% of them, their care veered off from what was recommended. And we found that patients whose care was discordant had a significantly worse survival. It took longer for them to begin whatever definitive treatment they needed. They had double the mortality rate, and their progression-free survival was also significantly worse. So having learned that lesson, we said the model needs to be a patient-centered model. It needs to be a patient with doctors in real time, at the same time, in the same place. And the reason for that is when you do a conference, you're looking at CAT scans and somebody's telling you a history. And you develop a picture in your mind of the patient, and you make those recommendations as if the patient is a 45-year-old triathlete, okay? But then you take one look at the patient, and you quickly realize, oh, not gonna work. And then what's the next recommendation? We don't have one. Or you say, well, yeah, this is what we gotta do, and the patient says, no, doc, I'm not gonna do that. Well, you have to factor in the patient's input as well. So we decided our program, our multi-D program, we have a conference But the conference is not the program. The clinic is the program, where the patient and their caregivers come, and all the doctors get to hear the story, see the CAT scans, talk to the patients, and then we actually take the patients back to the conference room and show them their scans on a huge wall like that. Show them their scans, CAT scans, PET scans, to try to give them a visual image of the thing that we're worried about. And that helps a lot. It helps us communicate better with the patients and gives them kind of a living image of why the doctors are wanting to propose what they do.
I think one thing we haven't talked about is we don't see everybody at the multi-D clinic. The PCORI grant, they want to know, is this going to work? And we have a lot of eyes on us about this, because if it works for lung cancer, it's going to work for breast cancer, it's going to work for colon cancer, it's going to work for pancreatic cancer, it's going to work for prostate cancer, it's going to work for everything. It's going to be the way things are done. So Ray and I are kind of feeling like we're kind of out on the edge here. So what we do is to prove that we have to prove this is worthwhile. We find 2 patients that are not in the study that are identical to someone in the multi-D clinic, so that when we finally come up with all of our data, we have, here's what multi-D did. Here's twice as many patients that were outside of multi-D, and this is how they did. It may not be any better. It seems like it ought to be better, but it may not be.
So we talked about that grant and the 3 specific aims. So our first aim was to do stakeholder feedback, so we could truly learn from people who really know, rather than assuming that we do just because we've been in the lung cancer field. And then the second aim was to actually implement a multi-D program that was rigorously benchmarked. So basically we said, it's not going to be multi-D until it's able to do this, and do it consistently. So having achieved that, we now say, okay, multi-D ready for comparative effectiveness trial. So now we're in the third specific aim, where we have a multi-D patient, can be any stage. The multi-D patients are defined as people who come into the clinic and get seen before treatment actually begins. So they could be people who already had a biopsy, or they could be people who just had an abnormal X-ray, and all those decisions have to be made. And for every multi-D patient, we go back across the healthcare system and look for 2 similarly matched patients, matched by radiologic stage and age and insurance status and a few other things. And what we want to do is roll time forward to see what these outcomes are going to be. Now, in our multi-D, we're actually taking a little bit of a risk, because there are patients who their doctors want to present because they want advice in the conference, but they don't want the patient seen. So they don't refer the patient into the clinic for whatever reason, okay? Those patients we're actually counting as serial care. So even though they get this discussion, because we believe that the whole point of multi-D is that closely, tightly coordinated care, primarily driven by the nurse navigator, with careful patient feedback about pros and cons of whatever it is that you're proposing, we actually feel that people who don't get seen in the clinic, but who get discussed in the conference, are eligible for our study, but they don't belong on the multi-D arm. So we're not calling conference multi-D. We're calling it, this is just standard. Because, people say things like, well, we've got a tumor board, so we've got multi-D. From our experience, we think that a tumor board, just the abstract discussion of the patient without the patient's presence and input, doesn't maybe quite qualify. And we'll see how the study, we'll actually be able to analyze all 3 groups. We'll have those who came and were seen in the clinic, those who were discussed but never seen in the clinic, and those who were never seen in the conference or the clinic, and see how that pans out.
How do you integrate the clinical trials potential, either at Baptist, if you offer clinical trials there, or if not, and no institution offers all the clinical trials in one location? But how do you add that piece to the mix of the multidisciplinary team?
So one of our key questions on every patient is there a clinical trial available? Yes or no? If the answer is yes, of course, the patient gets offered the trial. If the answer is no, then if there is standard treatment, we discuss it with the patient. If there is a need to go to a clinical trial that we don't have, we refer the patient to where they can get the trial. So, for example, I have, colleagues in SWOG and several other organizations. I know what some of them are doing. I personally send patients to Vanderbilt. I also send patients to MD Anderson quite a bit for everything, the whole span of lung cancer care, depending on the patient's desires and needs.
Go ahead. Okay, so I have quite a few questions. Like I said, it's extremely busy tonight. One's from Bonnie. She's texting me. What do you think of treating the patient rather than the stage? And is there an option for surgery for a stage 4 patient?
Oh. So you want to take that? Surgery for stage 4 patients?
Well, since you sent them to me, Ray, I think you could answer them.
So we think that there are subsets of patients with stage 4 cancer that can't be cured, and they need to, well, actually, it's a bigger question than that. There are patients who get tarred with a certain stage and treated for that stage. In hindsight, they probably are not that stage, which is why we're so emphatic about trying to be as sure as you can be about stage. So, for example, there are people who treat scans, PET scans, CAT scans, or whatever. Well, I did the PET scan, it showed cancer there, so that's why I gave chemotherapy. Like, well, did you biopsy it? Because if you do that enough times, you will find enough patients who the PET scan, the CAT scan was actually wrong. So there is a need to confirm stage as much as possible. Just to give you an example of that, we have this large database that we've collected over about 10 years in the region. We call it the Memphis Metropolitan Area Quality of Surgical Resection Cohort. If you look at the stage 4 patients in that database this is a surgical resection database. Everybody had surgery. The ones who are called stage 4, if you look at their 5-year survival, it's something between 40 to 60%. What's going on there? It's not that surgeons in Memphis suddenly have a cure for stage 4 cancer. It's that you can have more than one lung cancer at the same time, 2 different primaries, and your destiny is the destiny of each one of those 2 cancers, not that you have stage 4 disease. So it's very important to be aware of this group of patients who can be cured.
Let me explain that a little bit. We see this a lot. We see a patient that has one nodule on the left and one nodule on the right, okay? Most oncologists are going to say that's stage 4 disease. That means this one has spread to this side, okay? Actually, what you have is 2 stage 1 lesions, and those have all been included in databases as stage 4s, and they live for a long time because they actually have 2 stage 1s. Does that make sense?
Yeah.
Excuse me, go ahead.
So that's one subset. A very interesting subset that we're very interested in are other groups of curable stage 4. So a patient who has a lung cancer that has not spread into the lymph nodes in the center of the chest, the mediastinum, some of them can have the cancer spread to their brain. Well, that's a group of patients that may well be curable. The same thing with patients with a lesion in the lung that somehow gets to the adrenal gland. These are subsets of stage 4 lung cancer that we're very aggressive about finding, because if you took 100 of such patients and you did the right thing for them, you removed that tumor in the brain, removed the lobe of the lung that they had, dissected their mediastinal lymph nodes. If you had 100 such patients, anywhere from 25 to 35 of that 100 would live past 5 years. Whereas, if you took 100 garden variety stage 4 lung cancer patients with lung cancer pretty widespread, and you rolled time forward, the percentage who would still be alive is going to be much lower than that. So that's a subset of stage 4 lung cancer patients who actually behave like stage 3 disease. They actually have disease that can be cured, but it takes a certain specific type of intervention to do it. So these are stage 4 lung cancer patients who should have surgery, but not just to the lung, but maybe to the brain, to the adrenal gland as well.
And we have some great neurosurgeons that have bought into this completely. Memphis has a great neurosurgical community, and we got 2 guys that are just completely in.
It's a whole, you guys just identified for me an entire new a whole living room dedicated to identifying those subsets. I mean, it's a big deal. And it's a big question that comes up a lot. Go ahead, sorry.
Okay, so another question. Do you feel that before starting chemotherapy that a patient should wait for molecular testing results?
I tell my colleagues sometimes, I say, look, if I could take a pill for a headache versus get a surgical operation for the same headache, which do you think I would choose? Come on, it's not difficult. It's not a difficult decision to make. If we know that certain types of lung cancer can be treated more effectively in a less toxic manner, in a more socially convenient manner, why would you do anything else? And why would you not seek the information that you need to figure that out in everybody?
Well said. Okay, so last question. Is there a consensus on return of lung function correlating with decreased tumor size? And if so, should patients be hopeful for lung improvement?
For what? What was the last part?
For lung improvement.
Well,
You're the surgeon. You need to take this.
Well, I think that has 10 different answers. If you've got an extremely large tumor, it's already wiped out what function that lobe of the lung had, so your lung function is not going to be any worse. It's been clearly shown that minimally invasive surgery, where there's no disruption to the chest wall or the muscles, you can operate down to a much worse. I'm trying to think of how to put this with y'all. We do a lot of lung testing, and there's some people that just can't have surgery because their lung function is so bad from years of smoking that taking out a piece of their lung will put them over the edge to where they'll be unable to breathe. What we found is with minimally invasive surgery, we can drop that number down 10 or 15% because we don't disrupt all the other associated muscles that help you breathe. Does that make sense? So the answer to that is I don't know what she wants me to answer.
Sometimes, Todd, you have patients whose tumor might be, they have bad lungs, but it just so happens they have really bad emphysema in that lobe where the lung cancer is, and that's the one you're going to take out anyway. That's why we do the split function VQ scan sometimes to try to figure out.
That's right. There's a lot of answers to that question, yes.
There's another aspect to that also, because in my circumstance, actually when I was treated, my lung function has actually improved. But this is also something where a pulmonologist may be able to contribute, because in my circumstance, my pulmonologist firmly believes that cancer also has an inflammatory component to it. And if you're able to manage the inflammation through, inhaled steroids or something like that, as well as managing the cancer, that you might actually be able to possibly reduce the damage of the cancer as well as the inflammation, possibly even improve the lung function.
I agree with that, but I also think you're one of the most motivated post-op patients I've ever seen. I would imagine you did everything twice that they told you to do.
Not quite, but I asked a lot of questions.
So is this working? Yeah, so not to be too jaded, but I'm not that big of a fan of insurance companies. So it seems to me that the multidisciplinary evaluation is ideal. I mean, why wouldn't everybody want to do that?
We had that meeting.
However,
We had that meeting 2 weeks ago.
yeah, so that's my question. I mean, if you bottom line it for some insurance companies, you know, it seems to me it would take more time. It's not simply just adding 6 people's time. There's a conversation that happens beyond seeing people sequentially. It seems to me that would happen, which is part of why it's better. But so there, you know.
I'll be fair because I think, honestly, I'll tell you, Todd and I have these debates all the time. I honestly feel that in most cases, people are trying to do the best thing that they know how to do, including insurance companies. The motives may be misaligned. They're trying to do the best they can from there. So an insurance company's motive is to maybe cover lives, provide service, but also have something left at the end.
Can I just interrupt you 1 second? I mean, it's lovely what you're saying. I'm a psychologist, and I'm a relatively calm person most of my life, really. The few times that I've found a vein sticking out of my head about this far has been with an insurance company, and just 1 second's worth while I was enraged with a psychiatrist who was trying to evaluate whether my clearly in need of patient was going to be covered. I finally shrieked out and I said, I'm interested in this patient. You're only interested in saving money. Admit it! I was so mad. The guy, at least to his credit, said, that's correct. So I think, let's be reasonable. Insurance company is in business to make money. Yes. And so they just want to make sure they make money. They have a means to do it. So I'm sorry to interrupt you, but please continue.
I think if you're going to make progress, you have to try to understand where somebody's perspective, what somebody's perspective is, so you can then figure out how to align their pressure points with yours. Okay. So insurance companies are in there wanting to only pay for what they feel is appropriate to pay for, okay? So the onus is on us to prove the value of multi-D care. And in fairness to insurance companies, really that work has not been done. So multi-D is one of those great concepts that sounds good. Okay, all the experts recommend it, but you don't see it being done. What is the evidence to support multi-D care? It's actually very, very thin. You have a number of retrospective studies, you know, before and after, but when you look at them, they don't quite line up all the same. Some of them say, yes, this is good. Some say, well, it's not quite so good. So what we decided was, we are going to get in the business of proving the value of multi-D care. That's why we structured our program the way we did it, okay? And we said we're going to look at it from as many stakeholders' perspectives as possible. That's why we asked every stakeholder, what would convince you of the value of this? You tell us, including the insurance companies, and they told us a number of things. When we look at all the things that we were told, there's a lot of alignment, but there are some areas where people, you know, perspectives differ. So we're going to measure all of this. And the reality then is probably, at the end of the day, when we see the value of multi-D, it may be strong in certain domains, may not be quite so strong in other domains, but the idea is let's bring this all out into the clear light of day so that we can then, as a society, rates the real value of multi-D care, and if it proves to be absolutely clearly beneficial, I think insurance companies will have to support it then.
Yeah, and I think I agree with both of you. I mean, Hildy, again, talking to patients time and time again, I can't get A, B, C, or D because my insurance company said no. I don't know if Kathy's on, but her insurance company said, oh yes, we'll cover the fiducial marker placement, but not the radiation therapy. I mean, that's asinine, right? Things like that happen all the time. So I think, yes, they're in it for the money. It's a business. But I think they're in the business of helping patients. But what they need is the data and they need longitudinal data in order to prove the concept, which is unfortunate.
Without data, you can't blame somebody not to throw money at something. I mean, there's plenty of things like that.
But that boils back down to the money, the funding, and the research.
But I do agree with you. They're an evil crowd of people.
I wouldn't say that. I wouldn't say that. Honestly,
I'm joking, Ray.
I'm not. Sort of.
Well, quasi.
Trust me, I have to call them all the time to get permission to do simple stuff. So, it gets perks
I'm trying to manage. I got one more here, and then we'll go to you, Doug.
I just have, well, as of right now, I have one more question. For the newly diagnosed lung cancer patients, what are 2 questions that you would recommend them to ask their oncologist or their surgeon?
First question is, I'm going to merge the first question into 2 questions. What is my cancer? What is the stage? First question, okay? Second question is, what is the best treatment and why do you think it is? So I've actually given you 4 questions. But I think these are very vital questions. Obviously, what is the cancer, meaning histology and so on. So once you've told me I've got cancer, my next question is, how much cancer do I got? Okay? What is the stage? And then, what is the best treatment, and why do you think it is the best treatment?
That's what I was going to say, and how do you know?
But I think there's, it's just not that easy. It's not 2 questions. Why do you think it's that stage? Do you have, the tissue is the issue. Do you have a biopsy that proves it's that stage? And then if it's surgical, what kind of operation do I need, and who's going to do it, and how many has he done?
Okay, so I have a question to go back. How can you know that oncologist knows what the best treatment is for the patient? So do they know, that immunotherapy is an option, or this clinical trial, or,
So there's an element of comfort and trust that you have to have, and it comes from the answers you get to the questions you ask and the way the answers are delivered. So if you're asking your doctor questions and he seems to be getting irked by it, then maybe you need to think real hard about getting a subsequent opinion. If you ask a doctor questions and he tells you, I don't know the answer, but I will go look it up, that's a much better doctor than one who gets angry at you because you asked the question.
It boils back down to what you both have said a couple of times throughout this. Lung cancer is a serious, scary disease, many diseases really. So make certain that your physician specializes in lung cancer, that he's not, an oncologist who...
as far as surgery goes, there is a database available for minimally invasive surgeons that is that's very easy to get to. And there's one guy who basically, you've got to do 100 before he'll put you in the database, and you've got to send him your results, and then he puts you into it. I think there's maybe 25 guys in it. So I would, if I didn't know anything about this business, I'd love to have that kind of resource available. You guys ought to find out about that.
Danielle, one of our patients texted me via Hawaii. I have to be quite jealous. But she said if I were to recommend to a newly diagnosed patient being in the situation that she's in, she would ask, where is my tissue and how much do you have? Because she's always looking for what's in her back pocket. She's just like, find me something else for my back pocket for the next time and the next time and the next time.
So that's an interesting question, because let's assume that tissue was an original biopsy, right? And it showed X, Y, or Z. If the cancer progresses, does it make sense to go back to that original tissue or to re-biopsy the point of progression to see what's changed?
Yeah, so we're in the business of biopsies a lot. We know lung cancer evolves as we're actually going to spend a whole session at World Lung talking about this very matter in the educational session. And what it is that, first of all, the old tissue, the condition in which it is, you have to be certain about. The other is when something changes, there may be a legitimate question, is there a change in the genetics now? For example, we see patients treated with targeted agents who respond very well, and then something starts to grow. You start out with an adenocarcinoma, you get a biopsy, and lo and behold, you've got a small cell lung cancer. It's changed to small cell lung cancer. Wouldn't you want to know that? So we do err on the side of getting biopsies when it's safe and the patient is willing to do it.
Yeah, I always kind of go with, if it was me, what would I want? And I'd want another biopsy.
Yeah.
I mean, it's just, you know, maybe it's a waste of time, but a biopsy is kind of a cheap deal to do as far as how it's going to affect me.
And it can give you really
it may give new information. It may not. Do it.
Done.
It seems one of the big variables in your study would be how aggressively a cancer is progressing. You know, if you're comparing two patients not getting the multidisciplinary treatment to two who are, is there a big variation? And I personally have always been curious, you know, like how long did it take this to get to stage 4?
Yeah. Yes, so that's you're actually asking a very, very strong question about study design. We thought it through long and hard when we wrote this grant, because you know the gold standard study design is a randomized controlled trial. So you have one patient multi-D. So two patients come into multi-D. One you randomly say you go in multi-D, and we're going to kick you out and take your serial care. We didn't think we could do that ethically. I just had, you know, we debated it long and hard. We didn't think that was a practical thing we could do. So we decided that what we would do was the next best thing, which was a prospective matched cohort study. So we would take a multi-D patient. We would take two non-multi-D, but they couldn't be just two random people. They had to be diagnosed about the same time as the multi-D person. They had to have the same clinical stage with the basic CAT scan. They had to be in the same age range. They had to be of the same race. They had to be of the same performance status. So the performance status allows us to get a little bit about how badly the cancer is beating up the patient or not. And that gives us kind of a good surrogate for the rapidity of progression of the cancer. It's not perfect, but it's the next best thing in terms of study design, and that's how we did it.
Answer how long it took to get to be stage 4 in him.
How long? Well, it varies. In some patients, you know, we've seen, for example, in the NLST and the ILCAP studies that even though you were screening patients with CAT scans every year, you actually had a few patients who would just, in between CAT scans, show up with their lung cancer, and some of those patients actually had their lung cancer blow up, actually show up at advanced stages in between the annual screening scans. On the other hand, we also have patients who in our multi-D program we're seeing who finally make their way in, and then when we go back to their CAT scans, you know, we talked about 86 days, but if you look at the outliers, there were some that are a few years. So it's actually possible to have had a lung cancer, and then you look and you see how somebody has been kind of looking through a pinhole, pretending that each scan was a totally novel thing, not tracking back to things that were done before. So you see the natural history of a lung cancer is steadily getting bigger and bigger over the course of months or years in some of those patients. It varies, is the simple answer to your question.
Rick.
I got to go back to the insurance company thing, but you've had a lot of discussion since then. But my question is, early detection is what you're after, right? You want to know early. So CAT scans, how many are not done because the insurance isn't going to cover it, or it's because of exposure? I don't think the exposure is a big deal. My wife gets exposed every 4 or 5 months, and nobody seems to be concerned about that.
I don't think I've ever seen anybody have a CAT scan refused that I ordered. In fact, I think we over-CAT scan people. As I said earlier, you go in the emergency room, you're going to get a CAT scan if you have any kind of complaint, has anything to do with your chest. I disagree with you on exposure to radiation on a CAT scan. You would much rather have a minimal dose CAT scan than a regular CAT scan. I think a regular CAT scan is 200 chest X-rays.
Yeah, something like
it's like getting 200 chest X-rays. Minimally invasive. Low-dose CAT scan, I think, is like 10.
Claim,
I think like 10 chest X-rays. You don't want to have a CAT scan unless you need it, and obviously
I
she needs to be
understand
followed.
that, but we've had so many people that have been here that have gone for like months and some years, like over a year, of having symptoms and not getting the diagnosis that they had lung cancer.
Well, you're right, and the excuse being, well, we didn't want to expose you because we didn't feel you were at high risk. Athena, sorry, I'll get to you.
And also, I think they're afraid of possible positives that aren't correct.
False positives?
Yeah.
Yes, that's a concern because some of that is changing and that change will accelerate because Medicare has come out to agree to pay for screening. You see, you have to remember, in all fairness, that until the LCAP, ILCAP, and then really NLST trials, right? We didn't. The policy position was there is no screening for lung cancer. And that's not because somebody just woke up and declared that. It was because the NIH funded 3 major lung cancer screening trials in the 70s into the early 80s, but the technology they used was a chest X-ray, which in hindsight was just not good enough. All 3 trials failed, and these were trials done at the 3 of the best institutions in America, the Mayo Clinic, there was a Hopkins study, and there was a third one somewhere, I forget who did it, but they all were unified in their failure. So we went into a period of nihilism about this. Well, we know lung cancer, ideally you want to diagnose it at an early stage because that's when you're most likely to cure it. We know the people most at risk for it. Most people are of a certain age, with a certain smoking history, and yet when you link the 2 things, you can't show a difference in survival. That's changed now. So when we start disseminating screening programs into our population, some of that will change, not all of it. So the patient who does not meet the criteria for screening because they haven't smoked enough or they're not of the age will not have the ability to get a screening CAT scan. And the reason for that is that now you're really dwelling with slim pickings. The odds of finding somebody in that it's just a much bigger haystack, a much tinier needle now.
So with that, Sally, go ahead.
I was just going to say, when I did the ILCAP, it was told to us up front there are going to be a lot of false positives. I had nodules in all my lobes. I was told not to worry about them, and it took 5 years till one did grow, and it was cancerous. But when they thought they didn't have any more funding, the cancer center that was doing this said that I could get a low-dose CAT scan the following year if my doctor would write a prescription for it, my internist, and they would only charge me what the insurance company would pay because no insurance would pay for it at that point. At first, my internist said, no, I don't want you to have any more exposure to radiation. And I said, my mother had it 3 times. Her brother died of it. My paternal grandfather died. I may have quit smoking 15, 16 years ago, but I'm at high risk, and I'd rather run the chance of getting a little more radiation, and thank God I did, because that's when it was found.
We're going to have to edit from the front. I don't want to cut anybody off, but we are at our time, and I need to get my, as you guys all know, all of my thank yous in. I think this has been a really amazing discussion, and I hate to shut it off, but it's 2 hours. Sorry. So a huge thank you, obviously, to Merck, Lilly, Novartis, Bristol Myers Squibb, Celgene, Genentech, /Astellas, Penn TV, of course, for all of the hard work that they put in each and every month.